everyone, welcome to the National Library of Scotland and to this event, Edinburgh's HIV Story. I'm one of the curators who worked with the team from Waverley Care on the exhibition Blood, Sweat and Tears, Scotland's HIV Story, which this event links beautifully to and will provide wonderful context to. It will be my pleasure to introduce the speakers in a moment, but I would just like to welcome our online audience as well, because this event is being live streamed. And to let you know that at the end we'll have about 10-15 minutes for questions, so please do store them up until then. It is my great pleasure to welcome and introduce our chair, Dr Helen Zealley, and our speakers Dr Alison Richardson, Professor Roy Robertson, and Dr Ray Brettle. Thank you so much for being here and giving us this talk this evening. So, there would be a great deal to say about each of their careers, but just so that we can get started and into the heart of our subject, I will give you a very little précis one by one. So, Dr Zealley studied medicine at the University of Edinburgh, and in the 1970s she became involved with the emerging speciality of community medicine and worked within the Children's Service of the Edinburgh Public Health Department for 10 years. She was appointed Chief Administrative Medical Office of the Lothian Health Board in 1988 and Executive Director of the Lothian Health Board in 1991, a post she held until her retirement. Dr Richardson, in 1987, became Principal Clinical Psychologist, later Consultant Clinical Psychologist, and was based at the Infectious Diseases Unit at the City Hospital, Edinburgh. She also worked with the Community Drug Problems Service and the Community HIV team from 1994 till 2008, the Department of Genitourinary Medicine in Edinburgh from 1987 to 2008, and the Haemophilia Department of the Royal Infirmary of Edinburgh from about 1988 again to 2008. Dr Richardson was head of the Department for Clinical Psychology, Community Psychiatric Nursing and the Harm Reduction team. And now Dr Brettle, trained in medicine, developed an interest in immunology and became a consultant at City Hospital, then clinical director. He opened Edinburgh's first HIV and AIDS counselling and testing clinic. He was awarded a gold medal for his Doctor of Medicine in 1995, where he documented all the research that he had carried out in the field of HIV medicine in Edinburgh. Dr Robertson is Professor of Addiction Medicine at the University of Edinburgh Usher Institute. He worked as a GP in Edinburgh from 1980. He was chairman of the Scottish National Forum on Drug-Related Deaths for 8 years and is now chair of the Scottish Government's Advisory Group on Drug-Related Harm. He is also a member of the Royal Medical Household. So please join me in welcoming our speakers. And I'm now over to you.
Well, thank you very much, Dora, for your welcome, and thank you, everybody, for your welcome. Can I just check, can you hear me? Yes, okay. We're not having questions at the beginning, but what we would like to know is if you could put your hand up if you have had any sort of knowledge, involvement in relation to HIV/AIDS in Edinburgh over the past 40 years. So quite a few who will know what we're talking about, we hope. So I'm going to start by setting the scene for those particularly younger people, setting the scene for 1980, because that's when this story really gets going, around about that time. The first thing to say is that we're going to be talking about an infection that was quite widely involved with men who are homosexual. And at that time, homosexuality in Scotland was only relatively newly legal. So it was a topic that was not talked about, that the people who were gay were often put into quite difficult positions, long before all the pride marches and all of that. So that is one point. And the other thing related to sex is that sex was not something you talked about. And it certainly was not on television, etc., etc. Totally different from today. Does that make sense to everybody? Yeah. Right. So the next thing is to let you know that the health board at the time, the regional council or the local authority at the time, and the police service at the time had all three been through quite major reorganisations. Okay, so everything was a wee bit muddled, not exactly right. And the third thing is that at the time, Russia had invaded Afghanistan, and the Shah of, we called it Persia in those days, but the Shah of Persia or Iran had been got rid of, and both Afghanistanis and Iranians were sort of coping with their problems by exporting opium, which was being made into heroin. Okay, so that was quite important. And the final background, critically important subject, was Mrs. Thatcher was the Prime Minister. She was reducing the spending on the health service. She was working out that it was actually better to have all our products made in other countries, China, much cheaper to have things made in China than to make them here ourselves. So that as a result, we had growing unemployment, seriously growing unemployment. So that is the background that we were working in. And I'm going to start by asking Ray, who was working in the States in 1981?
82.
When a topic called AIDS suddenly hit the headlines and was a major concern. So Ray was there, sorry, Ray and Roy, I get mixed up all the time. Ray was there, and he's going to sort of talk a little bit about AIDS and how it was affecting everybody at that time. Ray.
Thanks. Hi. It's obviously difficult to know exactly how much everybody knows, so I'm going to start by just trying to have a simplistic explanation of what we're talking about. So AIDS stands for Acquired Immune Deficiency Syndrome. Okay, it was first reported in 1981 in a publication in 1981. Although there were probably cases that were identified retrospectively before then, but that's when it really hit the medical headlines. And it happened to be in mostly gay men at that time. Although, again, retrospectively, there were identifications of people infected by blood transfusion. The immune system, okay, is a part of your body that effectively recognizes foreignness, if you want to call it that way. It's basically anything that doesn't belong, and it uses cells and proteins to get rid of that. And immune deficiency is basically mean it's not working, okay, and you develop a number of things as a result. AIDS, the definition of AIDS, because at the time we're talking, there was no blood test. And the only way to define it was a clinical constellation of events, symptoms, mostly infections or skin cancers occurring in young people. And these were things that actually doctors knew all about, the presentation. It's just, usually it was associated when what was called immunosuppressed a patient. So in order to get a transplant, for example, you had to give people drugs that would damp down the immune system. And some of these events had been noted, but these were individuals who were young men and they'd had no such intervention. So that was the sort of scary bit about it. And the presentations were things like pneumonia, meningitis, a particular skin cancer, strokes, blindness, stuff like that, due to infections. And they were all actually infections that most people have had already. The immune system has controlled them, those infections, and then over time, as the immune system declined, these infections came back. When it happened, of course, nobody had any idea what the cause was. Lots of things suggested, drugs, recreational drugs, amyl nitrate, poppers was one of the things that people thought about. Lifestyle, whether you were gay or not, was thought to be the cause. But because although it was initially in homosexuals, it was also apparent in blood transfusion recipients and children. And so it was pretty easy to work out that it was actually some sort of blood-borne problem. The blood was transmitting the problem. And eventually, the virus, HIV, now called HIV, then called LAV or lymphadenopathy-associated virus, or HTLV3, was isolated in France, and then they managed to get a continuous culture of this virus because of the contributors in the States, which is why it ended up with HTLV3. Now we know that because we recently had COVID-19 pandemic, that a lot of these events happen because humans catch these things from animals. And the reason it happens is because we disturb the environment, we build roads, we knock down forests, and we come into contact with animals that we haven't been in contact with before. In the case of AIDS, it seems like the animalist primates in Central Africa, which was probably around from the 1920, and was passing through humans until about 70 when it exploded. And the reason it exploded was probably to do with drugs, travel, sex, people being able to move around. Whereas if you got AIDS in Central Africa in 1930, the chances are you would not meet many people, so you wouldn't pass it on. So that was the reason it was restricted initially, and then change of our culture, whoosh, out it goes. And I think, as has been said, my first experience was when I was in the States, when I looked after a couple of patients, and when I was coming back, I was phoned by a friend from blood transfusion to say, bring whatever you can back about AIDS because it's a hot topic. When I became a consultant, I spent 2 years talking about it, and the people that wanted to listen were not the clinical staff, they were the laboratory staff. And we can sort of mention that a bit later.
Right. So that's the background to the illness that we're talking about. But it was one that people kept very quiet about. But then, Alison, you've got a very important person to refer to, who brought it out into the open.
I think the first time I ever heard about AIDS was when we heard that Rock Hudson had travelled to France and was very ill. And he was treated there for a very long time with experimental drugs. And it was only when he returned to the USA in the middle of 1985 that he admitted both that he was gay and that he had AIDS. And he died very soon thereafter in October 1985. And for most people like myself, middle-class girl from Edinburgh, this was a completely shocking event, that this really handsome, beautiful man had died of this mysterious illness that none of us really had ever heard about. So his death brought to the attention of many people in the UK probably that there was a problem, albeit on the other side of the world, and nothing to do with Edinburgh.
Okay. So that's the background to AIDS. That's reminding us that it's actually an important topic. But Edinburgh at that time was actually struggling with a completely different problem that Roy was absolutely up to his, over his head, coping with. Roy, do you want to go back to the...
Completely submerged, yes. Well, my experience was about drug users. I mean, my clinical career was in general practice in Northwest Edinburgh for many years. But as an undergraduate and as a postgraduate, during training years, I worked in Edinburgh hospitals, so very few people who used drugs. And it was interesting that most of the referrals for people who who presented with a drug problem or required help went to the local drug clinic, the local drug dependency unit, which had been established in 1968 under the new regulations, and there was 200 established around the country. The Edinburgh unit was in the Royal Edinburgh Hospital, and a researcher called Moya Woodside reported the first 3 years. In 1973, she reported the first 3 years treatment, and it was entitled The First 100 Drug Users in Edinburgh. So that was the sort of context. Only 100 drug users had been identified in this new clinic over a 3-year period. And the demographics of that group were interesting. 65 out of the 120 that had attended the unit over the space of time were doctors or nurses. So we were dealing with a clientele that was quite clear. And interestingly, Moya said in one of her summary statements was that nationally, the UK's reporting system had said there had been a plateau in the number of people being reported to what was called the Addicts Index at the time in the Home Office. And she reflected that maybe we'd reached a peak in drug use problems. Interesting. And then something extraordinary happened. Something that really, even in retrospect, seems extraordinary. Within probably 2 or 3 years, we probably had several thousand, maybe 5,000 people in Edinburgh using drugs, injecting drugs. And the key thing was that they were injecting drugs. The key thing was that they were young, they were inexperienced. There was this new wave of pure heroin. I mean, this heroin was purity of 50%. And colleagues, friends of mine who worked in New York at the time, told me that this was something that they'd never experienced. Street heroin in New York was between 5 and 10% purity, and that was usual, that was the normal. So we were experiencing something, and it was the geopolitical events that Helen outlined at the beginning that really was causing this, but we were the recipients of this wave, as most of Western Europe was. So cities like Edinburgh were experiencing drug use problems. The thing that distinguished Edinburgh, I think, was the injecting. And that was brought about, I mean, we know, I think Ray knows as well, that the Glasgow experience was slightly different. I mean, I visited places around the country, Liverpool, they said not many people inject, they smoke the drug, they don't inject. But our drug users were injecting. It was a sort of culture that was just born out of nowhere, and that became established. And they were injecting in groups. They were injecting in groups because there was a poor supply of needles and syringes. There was no way that we were allowed to. It was illegal to supply needles and syringes to people who were known to be using it for something that wasn't medical. So people were accessing casualty units, wards, taking sin bins of used equipment and reusing it in groups. So what we had was a sort of scene set for an epidemic, and if you designed it perfectly, you couldn't have designed a better scene for transmission of a bloodborne infection. And I've got this sort of timeline in my head. I don't know if you want to do that now. I mean, I've got this timeline in my head, if I can find my specs, the way things unfolded over that period. So we're now talking about the period from 1980-ish up until the time when the test became available. As Ray said, there was no test available at that time. The test didn't become available until 1985 or early 1986. 84, beg your pardon. So we were dealing with a caseload of people who were presenting with hepatitis B, they were presenting with superficial skin infections, there were sudden deaths, there was a lot of unhappiness, a lot of criminality, a lot of the police were clamping down. There was people being sentenced to long periods in prison for relatively small amounts of heroin. And the timeline I had was that we had this realization in 1980 to 1982 that we had an epidemic of heroin availability, and that people were injecting in using used equipment, using used needles and syringes. And then the second point was the test didn't become available until 1985. At that time, we had a stored collection of samples because we'd taken a lot of samples from people who had hepatitis B, and the lab kept little aliquots of the blood that they'd used to do that test, and we were able to go back in 1985 when we were able to test and find out that there was a large percentage of those tests were positive, and they had been positive probably back till 1982. So after that, in my timeline, there was the, I wouldn't say the cavalry arrived, but Ray and his colleagues arrived, and the Ward 7A was set up. The GUM clinic was already established, but was dealing with cases, and we had people from agencies around the areas, and we had some extraordinary agencies in northwest Edinburgh, one called SHADA and laterally called the North Edinburgh Drug Advice Centre. And there were groups, there was the church, there was lots of people becoming involved, but it wasn't mainstream NHS staff. There really wasn't a system. There wasn't a system that was designed to deal with this. So very briefly, the other two points were the research that Ray had a huge footprint in leading into one issue in particular, heterosexual transmission, because here we had a caseload of young men and women who were infected with HIV infection, and there was a potential for a heterosexual epidemic. And this was something that really was for everybody was a significantly important feature of the Edinburgh epidemic as opposed to the gay men epidemic. And we did some research, and we collaborated with European colleagues, didn't we? And we actually published an article with many others around the country, Middlesex Hospital and Europeans, in the New England Journal of Medicine about heterosexual transmission, which was in fact less than we thought it would be. And finally, in my timeline, was the launch of effective antiviral chemotherapy, which happened in 1995, sadly too late for many of our patients. But in that intervening period, we had a caseload, and we had a caseload of several hundred people who were using drugs, and it wasn't just the individuals who were young, who were otherwise completely healthy, and who were unaccustomed to dealing with medical conditions, had no expectation that they would be ill, and we were dealing with their families and their children and their associates. So it was an extraordinary period of time.
I think the important thing to bear in mind, just to go back to the Mrs. Thatcher story, that a lot of these young people were unemployed, so they were wanting something to do. So they found heroin, they had good time, made them feel good, because they hadn't got a job. So that was part of the background. I think that's a fair thing to add into the story. There's also, now that a test became available in 1984, the haematologist who was looking after haemophiliac patients in Edinburgh sent some samples down to London to be tested and got a total shock when he got a message back to say that 6 of his haemophiliac patients in Edinburgh, who had only been receiving Scottish-based samples, plasma samples, that 6 of them were HIV positive. That was an absolute shock for the haemophilia doctors. So here we have Roy with his drug users positive and a few haemophiliac patients positive. And the haemophilia story was important because it was, I think, the first known transmission, heterosexual transmission, was a haemophiliac man transmitting it to his wife. So the concept that this is not just an illness for gay people, this is an illness that potentially we are all at risk of. And I think that that is a really important, that was a really important part of the story. And it took us back to a story that Ray's going to tell us about from 1969 in terms of health service staff. Just briefly, Ray, that's okay. The story.
Well, in 1969, there was an outbreak of a blood-borne virus called hepatitis B in the renal unit in Edinburgh. And there were other places in the UK that had similar outbreaks, but from the point of view of Edinburgh and the staff who, if you like, are looking after these patients that we're now talking about, 4 members of the NHS died as a consequence of that event. So 2 transplant surgeons, 2 technicians who work in the blood departments died as a result of contracting hepatitis B. And not surprisingly, therefore, people are very concerned about bloodborne infections and the risks to themselves in the NHS, which I think altered the way things were managed.
So here we have an illness that can infect anyone. It can be acquired through blood transfusion, through blood connections. They don't all have to be transfusions, or by sex. And importantly, the National Service set up a testing for blood donations to ensure that blood donations that blood donations were not infected, because that's obviously where the haemophiliacs had inadvertently been infected. But there was a concern that people would rush to the blood transfusion service to have their blood tested because they wanted to know, but we didn't want everybody rushing to the blood transfusion service to have a test. So Ray set up you.
Well, an alternative, it's called an alternative testing site. So basically, the problem was that the government requested that these clinics be set up to move people away from the blood transfusion service. So what is called by the transfusion service donor deferment. So the idea is you don't want people donating a pint of blood to find out if they're positive. So, and because most of the, up until that time, most of the centres had to do with sexually transmitted diseases, most testing was being done in the rest of the UK in GUM clinics. But the problem was, Edinburgh was different. These were individuals who wouldn't normally attend what was called an STD clinic, sexually transmitted disease clinic, because they didn't see themselves as being at risk of STDs. So we had to set up a site to attract drug users in to be tested rather than going to blood transfusion, which is how the interesting thing, which I think is referred to in the exhibition, is that one of the things that showed, which we didn't really know that much about, was how many of those individuals using injection drugs, how they travelled. And they travelled, a lots of places, New York, Italy, Spain, all over. The patient said to me, they reckon they could strike or get a hit within 4 hours of landing in any city. They would be able to get some drugs. And so they were moving around. And that's probably how the virus came back. Interestingly, the really major thing to say is later work shows that the drug-using epidemic and the haemophiliac epidemic came from different places. They're totally separate events. The drug users did not rush off to donate blood and cause the BTS problem, if you like. It was a different, we don't know where it came from, but it's different.
Okay. But meantime, there's Roy and his colleagues really coping with the drug users who are sharing equipment against all advice, but you were trying to get clean needles and syringes for them. So why were you not able to do that? Why were they not able to?
It was illegal. I mean, it was illegal, and we had some very interesting encounters with police and with the Lord Advocate and discussions. I found myself at one point sitting next to the Lord Advocate talking about, I hadn't realised he was the Lord Advocate until I said that we were actually giving people needles and syringes. And somebody said, you realise who you're sitting next to. And it was very interesting because, at that time, the criminal justice system was admittedly, and they admitted they were struggling with the problem. It was all very new. It was all very explosive. It was difficult. The drug squad in northwest Edinburgh had a mandate just to arrest people and to try and stamp out drugs. And it was all very small scale. and it took a long time to evolve into anything that was coherently going to deal with the problem. So dealing with politicians, dealing with the criminal justice system was difficult. Eventually, it became clear that this was it wasn't a criminal act. It was a public health act. It was a Good Samaritan Act, whatever you call it, eventually we managed to establish, or the politicians managed to establish, an experimental needle exchange clinic in a couple of sites in Edinburgh, and from then on things rolled out. But that was an extremely difficult time, during which we continued spread of the virus was undoubtedly happening.
We did have a bit of a discussion with the police to say, look, we're doctors, nurses, we've got needles and syringes wherever we want them. We're not using drugs because we happen to have needles and syringes available, but they just could not quite get that. Anyway, that was background there. And I'm now going to move to the fact that the health service was now in quite serious financial problems. But we'd had one of these management changes in the NHS with a new general manager. And he was asked by the government to set up a committee to talk about what we should be doing about HIV, the Taylor Committee. The Taylor Committee ended up with an absolutely incredibly important recommendation. Alison.
Well, but one of the recommendations that the Taylor report made was that they should employ a clinical psychologist.
There she is.
And here I still am. And to be honest, I didn't know very much about HIV apart from about Roy Hudson, but I had a trainee at the time who had worked at St Mary's Hospital in London, and he knew a great deal more about it. And working at the Royal Edinburgh Hospital in adult psychiatry, I was getting referrals of people who were terrified of becoming infected with HIV, or were absolutely convinced that they already had HIV. And we were well used as psychologists to working with people who had cancer phobias, but this was a completely new phenomenon, having people being referred to us with anxiety about AIDS. So my trainee suggested that I go and see one Dr Brettle at the City Hospital, because he had heard that he was very interested in HIV infection. And the two of us went up there and spent an entire afternoon just listening to Dr Brettle talking to us about HIV infection, about drug users, and about all the problems. And I was hooked, partly because he told me that there was a job going that had been recommended by the Taylor Committee, and it was actually a promotion. And that was possibly my main reason for going for it at the time. But in the event, I intended to stay for a couple of years and then go back to my first love, which was psychiatry, and I retired 22 years later, like these two. But I had come quite late to it, and when the Taylor Committee recommended that that their main recommendations, apart from the AIDS unit, was psychologists and 2 district nurses. And it made no mention at all of why a clinical psychologist might be useful. And I assumed that it was because these young people who were becoming infected were going to be traumatized by being told that they had an infection that was going to kill them. What I actually found, certainly amongst the drug users, was that very many of them were psychologically damaged, and that was why they had become HIV infected. And I remember one patient saying to me, "Oh, it's just the last thing in my life." His mother had died when he was very young. He was bringing up his 2 younger siblings. His father was never there. So for some of them, HIV wasn't the hugely traumatic thing that I had assumed. I think the other thing that's worth mentioning, and we've discussed this quite a lot, is that Edinburgh would not perhaps have had the reputation that it did if it had been an outbreak amongst gay men and a small number of haemophiliacs. It was because of the immensity of the drug-using problem and the fact that it would cause heterosexual spread. And it was the heterosexual spread that probably made Edinburgh such an important place, because everybody was terrified of heterosexual spread at that time. I don't think they cared an enormous amount about drug users. Roy?
You want to come in?
Well, yes, I just wanted to mention the McClelland report. You know, Brian McClelland was the director of the Blood Transfusion Service, so he was obviously a key player in the anxiety that, as Ray said, has been going around at the time. And the chief medical officer in Scotland asked Brian to convene a committee to look at what we should do, what the immediate reaction should be to this crisis of HIV infection in this drug-using population. And the key issues were needles and syringes, and were medical care, and were medical treatment, were opiate treatment for an opiate medical problem. None of which had been addressed before anywhere, really, and there was no guidance, there was no guiding lines, there was no previous report. And this report that came out, which was extraordinarily report, it was only 16 pages, which is, I think, wonderful for a report on a serious issue to do it all in 16 pages. But there was very few recommendations, but one was that we should supply needles and syringes. Second one was that we should deliver methadone, we should supply methadone to patients who had an opiate addiction problem, and we should set up clinical services. So that report was the first, was, as far as I can see, was the first anywhere in the world that actually addressed those problems in a formal government report. And it wasn't until a few years later that the Advisory Council on Misuse of Drugs in Westminster for the whole of the UK produced a report which was much more detailed but broadly similar.
The report that was produced said, actually, the spread of HIV is more worrying than drug use. That made it. Okay.
Absolutely.
So there was a second committee. The McClelland committee was really important at the beginning, saying we need clean needles and syringes. The second one was the one Alison's referred to, the Taylor Committee, as well as agreeing that there should be psychologists and all the other things. It authorised the spending of a huge amount of money on this HIV problem in Edinburgh at that time. It was money that had to be totally earmarked, and it was used to set up needle exchanges, nursing services, psychiatric nursing services. It's difficult to go through the whole list of everything, but it was a huge amount of money. So I would spend the morning at a health board meeting worrying about how we were going to save money on this and save money on that, and then go in the afternoon to a meeting about how could we spend this and that on the HIV problem, which was a very bizarre life to live in at the time. But it was critically important because it did help us to get through and sort of break the cycle. Maybe it was broken before, we'll never know, but it was really important. And that money was also available to allow the beginning of treatment when it emerged in the early 90s against HIV. Now I'm conscious of the time. We've had so much to say, and we've still got loads more, but I'm going to ask each of them to wind up with any particular critical thing they want to say, so that we can have plenty of time for you guys to ask questions. Okay, so, Alison.
There are so many critical things, but it's still the patients were at the centre of everything we did, and two psychologists in the audience who worked with me, Carol and Chris. And I think probably all of us remembered the patients very well when they were, particularly Carol in the early years when she was working with gay men at the Department of Genital Urinary Medicine. And it was heartbreaking to watch these young people dying at such an early age. So that probably stays with me more than anything else.
I don't have anything to say.
Carry on.
I'm skip over and you go room.
Well, I think, like Alison, my experience was very much with patients, was about patients, and it still resonates today. The many young people who didn't expect to die, who died in tragic circumstances, and how drug use and HIV, of course, were stigmatised from an institutional level, right from government right down to local communities. The level of stigma was something breathtaking by today's standards, although it still exists.
Still exists. Yeah.
And you know, and I I never liked. I mean, my focus was always about clinics and patients and cases and things. But you do get drawn into the political arena, and I felt an obligation to have some sort of, to do some sort of advocacy on the part of that group, and still do. And regrettably, I think that there is still a lot of very poor responses in Westminster government towards our drug use problem, which I think is disgraceful. But we've lived through such chaotic times anyway. It's hard to separate out anything. But I think we still need to, the lessons that we've talked about, the lessons from that era, resonate, I think, down the years to our present situation. And I'm glad to sort of see that people are interested in it.
Andre?
In terms of stigma, I think the key thing, as an example, not just in government, you look at HIV. There's a major committee called a group of doctors called BEVA, and there is a treatment called PrEP, pre-exposure prophylaxis, which is widely available to individuals who take part in sex. It is not, however, available to anybody who injects drugs. And that is a recommendation from people who look after HIV patients. And I think that's a best example I can come up with of continued stigmatisation. And that still exists today.
One interesting thing about that prophylactic treatment is that President Biden in the States, I don't know how many billion dollars he's invested in it so that it's widely available in Africa, so that the large numbers of still infected people in Africa can get it. And I'm just going to finish with my view, which is that the people working in the HIV Story in Edinburgh and in Scotland in general, but it was primarily in Edinburgh, were fantastic. The time they gave to it, the involvement with each other, the working together, not just in the health service, but in the regional council, the social workers, the teachers in education, all the voluntary groups, and there were lots of them doing amazing work. It was absolutely fantastic. And there was a group of researchers came from a university down south and sort of explored what we were doing. And the one thing, the critical thing that they reported at the end was the extent to which coordination between all the different people had been really, really impressive. So now it's over to you for questions. Yes.
Very simple.
If you can bear with me 2 seconds.
Thank you. Very simple question. Can you just clarify the difference between HIV and AIDS?
Oh, yes. Right.
Well, AIDS was a clinical definition initially, okay, but it effectively is late-stage disease. So you can break down the HIV infection in people, over which takes about, in most situations, about 10 years. So it takes 10 years to get from being infected to developing AIDS, approximately. 50% of people will develop AIDS after 10 years. And it's simply a progressive loss of your immune system. Well, it doesn't happen over 10 years. It happens, it's a funny graph, lots of virus drops off after you've been infected, very little virus, and then in the last 2 or 3 years, the virus shoots up again. And that's the hallmark of your immune system failing, or lots and lots of T cells are infected with HIV at that point.
But that 10-year period is without treatment.
Yeah. Sorry,
we now have treatment. So.
Now, again, one of the things to remember is that at the beginning, when there wasn't a blood test, people who were given a blood transfusion developed AIDS within 2 years, okay, and probably would be dead in 2.5 years, because they were given with a pint of blood a massive amount of virus in one go. You get more with injection drug use, you get a smaller dose with sexual transmission of any sort, you know. So it's partly related to how much dose you get, how long you have, in a sense.
The most of that, of course, we didn't have any clue about by the early 1980s.
Yeah.
So a lot of the modelling that was done, for instance, in the Taylor report, was done on the basis of what was happening in America,
Yeah.
where people were already getting ill. So they were years and years in front of the epidemic in Edinburgh. So we got lots more money.
Sorry, I just interjected. Thank you. Mine's a little long, I'm sorry in advance. How do you think that as a species we've adapted to the fear and stigma surrounding infectious disease? What significant changes did you notice between this pandemic and ours, other than the targeted concepts of blame surrounding homosexuality and drug use? How do you think that we can provide better coping strategies and networks to support our community when the next infectious disease presents itself?
Well, the biggest gear, if you like, motivator of change is fear. Okay, and that's what affected change in HIV, whether it was drug policy or whatever. And you saw exactly the same thing with COVID. So, unfortunately, governments find it very difficult to plan for this nebulous future nasty that is coming down the road. Until it hits them, then they will respond. I find it very difficult to persuade them to, and certainly, as you know, they've been saying, they know all about this with COVID, but there's no planning for the next one.
Well, that's right.
Can I just say,
Yep.
I think the biggest failure is in the infrastructure. I mean, I think if you've got a solid infrastructure in any service or in any agency, then you can adapt and you can cope with things when they happen. And I mean, different viruses cause different even problems in different classes of people or groups of people or individuals. But if you've got the infrastructure that's there, one of the wonderful things about the NHS is it's just there for everything, you know. And if it's properly funded and properly supported, then it can adapt. But it can't adapt if it's not, you know, adequately funded.
I think one of the things I would like to chip in as having been Director of Public Health, I think if instead of trying to respond to it from 10 Downing Street, if you tried to respond to it from departments of public health, there might have been a different response.
That's a question for Roy. I was interested in the 1960s addicts register, having a lot of doctors and nurses on it, and not the sort of people who were drug addicts in the 80s in Edinburgh. Do you think that was a consequence of the war on drugs? And when do you think the war on drugs will actually end?
Well, I think the doctor's issue is still there. I mean, I think they just don't appear in the figures. You know, they don't appear in most people's reports. And, you know, they go to, I mean, there are clinics around the country to help doctors and nurses who are addicted. And anaesthetists are the ones that seem to get it worse. But so that still happens. Yes, so I don't think. I mean, I think the trouble with the war on drugs is, you know, I recently had a conversation with a chap who is an expert in war, and I said to him, you know, all these things. His research is all about what causes war and why, you know, people can't negotiate and people can't. And it seemed to me to apply to the war on drugs. You know, I said, well, you know, why can't we get people just to come to an agreement about how we manage this problem? Because, you know, it's a massive problem, it's multifaceted, it affects the criminal justice system, it affects health, it affects communities, it affects everybody, and everybody knows or has it's like alcohol, you know, everybody has an experience with alcohol, and most families have a bad experience with alcohol somewhere. So why can't we have a strategy that deals with that? And I don't know the answer, but I think unfortunately it's characterised as a war, you know, which means that you throw arms at it and you batter it to pieces, and that clearly is not the way to deal with it, and it's failed constantly. I don't know if that answers your question, Rob, but.
So, and there are, here's questions, sorry. You have to be quite
That'll be
short.
difficult, yeah.
Thank you. How important do you think Milestone House was in public attitudes and their
Well,
changing?
I'm so glad you asked that, yes. Helen, do you want to say?
I'm glad you've asked that question because we ran out of time because Milestone House was next on the list to talk about. Absolutely critical. Alison, you spent quite a lot of time.
I spent a lot of time at Milestone House, mainly looking after drug users, although it was set up originally by Scottish AIDS Monitor, particularly to help with the problem in gay men. And it was a gay man who invented Milestone House. But in the end of the day, although they built four, what would you call them, four bungalows, so that they could house different risk groups in different bungalows. In fact, it was almost entirely taken up with drug users, and gay men were very reluctant to go in, and very understandably, because working with drug users, they are not polite and grateful and behaving towards their doctors and nurses as you expect patients to do. They were quite the opposite. So it was almost entirely drug users who stayed in Milestone House, and many of them died there, and died in much more pleasant surroundings than they would otherwise have done.
Thank you for the question.
Hi. I was just wondering if you faced any barriers or stigma from other healthcare professionals.
You mean about...
Actually working with patients themselves, did any other healthcare professional, at the time maybe it was something not understood, did any of you actually face barriers?
Well, the answer is yes.
Yeah.
And most of them didn't really want to have anything to do with our patients at all. So we did become a little band of brothers really up at the city hospital.
But they weren't, yes, there was a lot of... one of the antagonisms was actually to do with the money. Okay, the health service was short of cash, and suddenly this group of individuals who were not perceived to require a lot of help were getting lots of money, and the rest of the health service was getting less. Because as always, just because we got a whole load of money, it meant everybody else got less. There wasn't an increase in the pot, really, was there?
Well, no, it wasn't quite like that, but that's a different story. But I think it's an important question because these patients needed help from dentists, from opticians, from all sorts of other specialists. And I think you had a...
Well, we had to collect...
A collective.
I collected a group of people who were interested. I mean, there was no point saying to a dentist, right, you're the dentist for the HIV patients, if they weren't interested, because nothing was going to happen. Or, so I collected the ophthalmologist, the neurologist, particularly the children. The children's doctor, Jackie Mock, was a colleague of mine at med school here, and, I phoned her up and said, oh, we've got a few kids here, what do we do about it? And sort of inveigled her in, and that was it. She was really sucked in.
To deliver the babies.
Yep, and so you had to do, but you're absolutely right. We weren't particularly well liked for the fact that we were looking after, and there was, amongst some individuals, there would be the fear that we would pass it on to them. I mean, because that was one of the big, it was a very unknown setup.
I think that's important. At the very early stage, there was this fear of contamination,
that
you might be infected. And,
very, very
I mean, it was certainly quite tangible in our practice, which was seen, regrettably, as an epicenter. I mean, partly because we just gathered the data. I mean, there was plenty of other centres, but, I mean, and then people wouldn't come to our surgery, and people left. And we were asked by the health board to absorb another neighbouring practice. A lady had retired, and people were shocked and horrified that they thought they had to go into that building because that was where there was AIDS.
And you might catch it.
You might catch it. Yeah.
Sitting on the chair.
Yeah.
I mean, and that's the level. I mean, it is really important to understand that level of concern existed amongst other patients, individuals, as well as other medical staff, because the medical staff weren't necessarily any better educated than the rest of the people.
It was far, far more scary than COVID. Far more scary. It's just was real. There's a microphone 2 rows behind you, George.
Can I just ask my question? I have noticed that you've talked about drug users, you've talked about gay men, you've talked about haemophiliacs, and actually the global issue affected Edinburgh as well. And I feel that we shouldn't be talking without mentioning the fact that there were quite a lot of people living in Edinburgh who'd either travel somewhere and come back with HIV, or that they had travelled to Edinburgh to start a life in Edinburgh and had horrific experiences as a result, and quite often subjected to stigma on different sorts of levels. And I don't want this to be finished without talking about some people that have had even more problems to cope with.
Stigma. George. Is this the last one?
We've got one more. Two more questions.
Just on the question of fear and stigma, I wonder if you'd say something about the fear and stigma that occurred in the middle of the 1980s when tests were available but no treatment was available yet. And people just didn't go for tests because they couldn't get any medical insurance if they had even been for a test.
Yes. I mean, that was a big problem, persuading people to have a test, and the insurance, the question about insurance was a difficult one, and that people wouldn't be able to travel, they wouldn't be able to get travel insurance, all sorts of things, if they were known to be positive. After all, if you're positive, you won't get to fly a plane anymore, will you? I mean, you know, pilots were very definitely, initially, because of the fear of brain disease, were banned from flying. I mean, it was that bad a sort of scenario. So you're absolutely right. Lots of people wouldn't come for a test, and it was a matter of, trying to overcome that, which included trying to persuade the insurance people to behave better.
But can I also say that if people were tested, they knew that they would have all of us on their backs getting them to change their behaviour. So many people didn't want to have a test because they knew that we would then be banging on about condoms endlessly and about not injecting or sharing needles.
We didn't talk about condoms. There are 2 questions apparently at the back, and I think
Hello, I'm Dave Carson. I used to work on the Needle Exchange back in the day, voluntary sector in the NHS. I've just got a question which is related to testing, really. There's some people that maybe didn't get a choice about testing because they were in Her Majesty's pleasure, and I just wondered if you've got any experiences or thoughts about the prison environment, particularly Saughton and Remand, Cotton Vale, Polmont Young Offenders, and what happened there, and also about the transmission within the jail, because there was injecting going on.
We could have a whole session on that. I used to go and I did a clinic in Saughton for quite a long time, although I eventually stopped doing it because actually the reason I stopped doing it was I insisted the patients come to the hospital because they got better care when they came to the outpatient clinic. The Scottish office didn't believe injecting occurred in prisons, and I remember talking to a guy, and they only believed it when one patient lost his leg because he injected into his femoral artery in prison, was admitted to our place, and that was the turning point when they said, oh yeah, there is a bit of injecting going on in prison. So, big problem. But I can see their difficulty. How do you hand out needles and syringes, which are weapons, in a prison? But you'd have thought that was obvious, you just give a methadone, but that was a really difficult step. But eventually we got them to do it, but it took a lot of persuading, absolutely. I mean, and you're right, eventually testing was introduced, but it was very difficult. If you were in there, you couldn't get out for a test, and did you want the rest of the prison to know that you'd had a test?
Okay, there's a question online.
Yes, we have a question from Alan Rogers online, who would like to know if you have any comments on the hospice development in Edinburgh. Speaking as someone who treated patients with Kaposi sarcoma, speaking at the Marie Curie Hospice took in his patients before the one in the city opened.
So was it asking what the hospice was doing?
Yes, I think so.
Well, it's Milestone House.
It was a special hospice. for HIV?
It is the case that, I mean, there were patients with composers who were presenting before, you know, and there was and yes, they could get into the Marie Curie, but eventually the routine hospice setup, if you like, was going to be overwhelmed, which is part of the reason for the driving force to have a dedicated hospice.
Is this a question about cancer as opposed to HIV? Because, I mean, the hospices, the traditional hospice units were largely about treating elderly people with cancer, or people young ages with cancer. And HIV was not cancer, and it was deemed to be different, and therefore was outside their sector, so they were reluctant. And
important to remember, of course, that Kaposi's was an infection. It's HTLV4. So, you know, I mean, most of the cancers that occur in AIDS are actually driven by infection, because they're caused by infections, which is why it happens.
But there were cases that occurred before Milestone House existed.
Absolutely.
And some of them did get places in Marie Curie.
But it became increasingly difficult.
Many patients died at home, and I mean, I'm not sure that's widely recognised.
Yes.
I mean, I was amazed by how our community in North West Edinburgh coped. Parents coped with relatively young children dying of an unexplained infection. And I mean, that was extraordinary, and that was something of a novel, a different experience, I think, for GPs.
And there was another final thing, and this is a final thing. There was a final thing that once treatment was introduced, there were people who had assumed they were going to die within the next few years, and they were on treatment, and they weren't going to die. So it was a different psychological challenge for those people. I just want to thank everybody for being here and for your questions. So thanks.
That does bring us to a close. I know we could stay on and talk, and there are probably more questions in the room, but we have wonderful research resources here at the library, so if you've been interested in all of the nuances and the topics we've covered within this very large topic, the resources are here for you. So thank you for our online audience and to everybody in the room, and for your wonderful questions and reflections. And thank you again to our speakers. Thank you so much.